the underlying patho, that's where you're going to have your interventions. So type 2, like 95% of all your diabetics are going to be type 2. Okay, 95%. So only about 5% are type 1. So, it is very common. We're seeing it more so in adolescents now and younger people, not just older age as we get sedentary in our lifestyle. And so, again, you've heard about it's a matter of insulin resistance and inadequate secretion. So some reduced production, a lot of insulin resistance. Okay, and which way it is in which person is what we have difficulty kind of teasing out. And so, it's really complex and it's not a one size fits all. Okay. There are so many factors that enter into development of type 2 diabetes. However, of the two types, of the two major types, 1 and 2 has the most genetic predisposition. Right. 2 has the most genetic predisposition. Right. And of course, there's metabolic, there's environment, it's sedentary lifestyle, the foods you eat, you are what you eat. If you eat a bunch of junk foods, guess what? You're gonna be a junkie, okay?
Sorry, you said 2 is more genetic than 1?
That's correct. I did say that. Why? Did you hear something different?
This time. No.
Right, let's go with your stats. Okay. Only 10 to 15% of your type 1s there's a genetic relative, somebody who has type 1. Okay, so, but if you look at the type 2s, like 90% of them do. And this is the predominant type of diabetes. Okay. So yes, this one is much more, there's a much stronger genetic predisposition. Okay. Ethnicity plays a role. Again, there are many genes. It's not just one, so we can't identify a specific chromosome and et cetera, et cetera. Okay, obesity, sedentary lifestyle, and the unhealthy diet. All of that kind of goes together. And so these are your major risk factors, which you've probably gone over ad nauseum. And, so when we look at the patho of it, it's truly the malfunctioning of these feedback loops between secretion and, what's going on in the cells. Okay, and so your beta cells, yeah, they can absolutely decrease in their insulin production, especially over time. So the insulin resistance is really what kind of like messes up the mix, right? So what happens is you have this kind of insulin resistance. The receptors they're bathed in glucose, and the glucose is secreted through it's circulating through your bloodstream. The pancreas is detecting high levels of glucose. So the beta cells are steady, churning out insulin. However, it's not really finding the receptors, or it's not doing the job. So high levels of insulin actually have, when they get into the cell, inhibit glycogenolysis. So you have high levels of insulin that are circulating, but they're not able to cause the receptor to open the gates and allow the glucose to go into the cell. So the net effect is glycogenolysis. which means now, in addition to having high glucose in the bloodstream, high insulin in the bloodstream, you're breaking down glycogen stores. And what's happening to that? High levels of glucose, more glucose in the bloodstream. Okay. So here are your beta cells and they're chugging along and they're saying, come on, guys, we gotta get these glucose levels down, burn out. So over time, your beta cells burn out. Bottom line, does that make sense? Sort of. Yes. Yeah. You just can't, they can't keep, it's like you all. You need breaks, right? You need breaks between lectures, you need breaks in lectures, you need breaks between semesters, you need spring break, I do too. Okay. We have all this going on, okay? You just can't keep doing this before you burn out. Well, the beta cells are doing the same thing. If they just keep getting it, and they keep churning out and manufacturing insulin, it's not able to do its job, okay? So you end up with high insulin, high glucose, and then even more glucose because you're breaking down your glycogen stores. Because the insulin's not getting into the cells to inhibit glycogenolysis. All right. So some of the organs that are most affected by the insulin resistance are your liver cells, your fat cells, and your muscle cells. Okay. And so all of this is going to, culminate in this type 2 diabetes. The beta cell, this is just kind of the process. Okay, it's the resistance. It's working. Yeah, and then it's going to become, okay, there's all this other kind of stuff that's going on. So these beta cells are working overtime. If you have genetic susceptibility, and then they're constantly producing, okay? They're being subject to all this extra work. To add a little bit more to it, because I was actually delving into this a little bit more. In the adipose cells, okay? Now you all were in the cadaver lab and you got to see some adipose tissue, right? Okay, especially in the abdomen, mesenteric fat and stuff like that, right? Now, I can't remember what your the cadavers, the donors were like. However, there's often a difference between the types of fats. Was there a difference in the two bodies that you all opened up? Yeah, tell me about it. Somebody, Ashley, go ahead and tell me about it.
The male cadaver, he was just more barrel chested in general, so he had more of like the abdominal fat rather than like, and even like difference between genders, like women are going to carry it differently in like hips and thighs versus him with his barrel chested, it was more in his abdomen. Hers is a little bit more sparse throughout, and then like packed in like by the hips, thighs. Like that.
Okay, so some of it's like kind of like packed in different areas. So what happens? Now, how much have you learned about suturing like subcutaneous tissue? Did you learn anything about suturing subcutaneous tissue yet?
Yeah.
Okay, what did you learn?
How to do it. It's really hard to evert that
Top on
much
the
skin.
Yes, yeah, well, of course you evert, you evert your skin. Sub-Q is just the opposite. You do everything opposite. You start low and you go up and circle around and you tie down deep. Okay, do you tie it tight? Why not? Why not? Circulation, right, circulation. So the circulation in adipose tissue is not that great to begin with. Okay, and so you just want to kind of bring it together. If you tie it too tight, then you can compromise the circulation. Okay, well, let's take that and think about this with diabetes, type 2 specifically. as the body is storing and all this extra triglycerides and fatty acids and mostly triglycerides, carbohydrates, which become your sugars, stored as triglycerides. Okay, and it's packing it in all this fat, right? So instead of being a nice loose kind of network, now you're getting more and more jammed into there and packing these adipocytes. Okay, what that does is it fills up the area. It makes it way more dense. So what do you think that does? What's the net effect that has on the circulation? Yeah, it's gonna compress it, exactly. It leads to ischemia. Okay, it leads to ischemia in those tissues. When you have ischemia, what does that set the body up for next? Inflammation. You got it. So type 2 all of this process actually leads to this chronic state of inflammation that you hear spoken about in type 2 diabetes. Okay, so this chronic state of inflammation, because you're going to have the release of these cytokines, you're going to have the release of, all these different, inflammatory chemicals that then are circulating throughout the body. That net effect, and I'm not going to ask you all this, so that net effect is to actually, it decreases the amount of, it has a negative effect on the endothelial cells that are lining the blood vessels and decreases the nitrous oxide. Nitrous oxide is a what?
Vasodilator.
Vasodilator, okay? And so now you lost your counterbalance to bradykinin. Bradykinin is a vasoconstrictor, okay? So now you're shifting over towards the vasoconstriction side. And then what's that going to lead to systemically? High blood pressure, hypertension, okay? And all that endothelial dysfunction then becomes, it further goes that, so you've got this chronic inflammation. What else goes up in inflammation? And cell breakdown. What other molecule? That can be negative, but it's necessary. Cholesterol levels go up. And so the whole process actually triggers this, this inflammatory kind of chronic low-grade inflammation, endothelial dysfunction, okay. Increase cholesterol levels, circulating cholesterol levels. Now you've got a weakened endothelium, you've got increased macrophages. They're going to take that cholesterol and drive it down into the walls of your blood vessels. Now what do you have? Atherosclerosis. Okay, you see the bigger picture now? How this is all intertwined. It's really quite amazing. Okay, so this slide, this is kind of what I expect you to know at this point. Okay, yes. Overall, beta cells are they're going to decrease production. Yeah, sure. Not so much, because diabetes 1 is necessary. It's more localized inflammation initially in the pancreas. However, in that stage. In diabetes 1, it's not the same. Okay, although in diabetes 1, ultimately, because of the altered glucose and stuff like that, it's going to cause similar problems. Okay, high glucose levels across the board, okay, across the board are going to cause dysfunction in your cells and in the endothelium. Okay, so That's another component to it, and with type 1, it's more the glycosylation that occurs in the different tissues, especially those endothelial cells. Okay. And when you have endothelial dysfunction, what does that lead to? What can that lead to? In addition to,
Increased capillary.
what else can occur? Damage to endothelium results in what? Yeah, clotting cascade. Very good. So clotting cascade. Okay, so if you have dysfunction or a threat to any of these cells, they become dysfunctional enough that it's past the point of no return. They're at risk of triggering clotting cascade. Yes.
Is the release of nitric oxide also related to the triggering of the clotting cascade? With like the,
Well, all the lack of vasodilation and the vasoconstriction can actually narrow the lumen and cause more effects, yes. It's pretty fascinating. It's very, very complicated, okay? But that's just kind of talking you through the bigger picture of it. As far as, you know, the lifestyle, I just spelled out what I told you on the previous slide. So, you know, all the diet, the sedentary lifestyle, high lipids, you know, that's going to promote this whole insulin resistance. And then the chronic inflammation that occurs in starting with those adipocytes. Okay, yes, right.
What you just described, that's the glucose process, right?
Yeah, where are we at?
On the right, highlighted, right?
Like, glucolipotoxicity, yeah. So all that's gonna favor insulin resistance, chronic inflammation, throw in your genetic susceptibility, and then your beta cells are ultimately going to burn out. Okay, that's the bottom line. And yes, there's a whole host of things that occur along the way. And anything else thrown into the mix that results in oxidative stress, right? Including infections, including just emotional stress. You know, all of that is going to make matters worse. Why? Because it stimulates glucocorticoid release. And your glucocorticoids are your stress hormones that are counter-regulatory to insulin. So their job also is to do what? Raise glucose levels, okay? And essentially negate the effects of insulin. Okay, so stress, you hear about this constant, like chronic stress leading to obesity. This is why, is because chronic stress, chronic hypercortisolism is it inhibits the effects of insulin and raises your glucose levels. And stores fat as well, so. Yes,
Sorry, I don't know if we talked about it or not, if I missed it, but we're talking about the insulin resistance. Is the insulin resistance being caused by the chronic inflammation or? Like, I guess I'm just curious, like, what's causing the cells to be resistant?
so. One of the theories, and again, we're still in theories, is that it's like other hormone receptors. Okay. If you're constantly being bathed in this, it's like this very sugary environment. Okay, essentially you become immune to the sugar. Okay, and it's sort of like a down regulation if you will, of the receptors. But in this case, they just become less sensitive to circulating levels of insulin. Because of just constantly being bathed in high glucose levels.
Thank you.
You're welcome. All right, so nutritional factors spelled out for you. What's interesting here is that, you know, all the carbohydrates, the high fat, high carbohydrate diet, of course, that is basically glucose and lipids. Actually, that causes a spike in your reactive oxygen species. We talked about those last semester, your ROS, okay, not review systems, but reactive oxygen species. And that is a promoter of inflammation as well. Physical activity, the lack thereof, also leads to low-grade inflammation, actually metabolic inflammation, such that intentional weight loss can actually improve the sensitivity of your insulin receptors, God bless you, and it actually can produce anti-inflammatory cytokines to fight those pro-inflammatory cytokines. So physical activity is healthy. I was talking about the cholesterol levels, the elevated cholesterol levels. Okay. Exercise produces what kind of cholesterol? HDL, okay? Sedentary lifestyle and this pro-inflammatory state, high triglycerides, all that, what's that gonna produce? Right, so it lowers your HDL, raises your LDLs and your VLDLs. Okay, so there's a whole theory between gut dysbiosis leading to insulin resistance as well. Not much is known other than healthy gut bacteria lowers, you know, decreases that insulin resistance, and, you know, unhealthy gut bacteria promotes insulin resistance. So, metabolic memory, unfortunately, the glycosylation that occurs long-term from uncontrolled diabetes, and it occurs in all kinds of cells that, think about some of the cells that don't necessarily reproduce or die, like nerve cells, heart cells, your myocardiocytes that aren't readily reproduced, that once they're there, they're there. So there's this certain metabolic memory that continues to exist even after sugar levels get under control. So what's the importance of that? The importance is addressing it, identifying it, and addressing the glycemic control early to prevent some of this glycosylation from occurring and leading to some of the complications of diabetes. Make sense? Yeah. Earlier the diagnosis, the earlier the good management and optimization of glucose levels, the better the long-term outcome is. Because even though, you know, even though you find out and you address it, if it's uncontrolled for a long period of time, damage is done. That there's a certain amount of damage that's done that cannot be undone. And you say, how can that happen in this day and age? Okay. So one of my best friend, well, she is my best friend from my undergrad college. We've been friends for 4 years. You know, she's highly intelligent, like super brainiac. Okay. And she called me up, she's like, yeah, I'm gonna go see the doctor, I have to get, I have to do this, I have to do that. I haven't been to a doctor in 4 or 5 years, she's my age, said, what? She's like, well, I know I have allergies and but I'm having this problem and blah, 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 blah. I'm like, okay. Like, her mother's just got diagnosed, her father dropped dead last January. Okay. Her mother has breast cancer that went undiagnosed and here she is, and she's just like not taking care of herself. So I'm like, just go get some blood work done, try to minimize it. And her glucose came back at fasting came back at 282. Fasting. What was her A1C?
13.
10.2. Very good, Lydia, on it. 10.2. A1C 10.2. What's normal? Well, what's the diagnostic for diabetes?
6.5.
6.5. You're gonna be the best class.
Actually, don't know where that just came. Somebody record that, you got that
like-
on recording.
Yeah. Medications. We have colonoscopy. Probably at least just do Cologuard. Come on, just do Cologuard. The girl who's got she's like a millionaire. I mean, with all her assets and stuff. She was vice president of NRG when she was in her 30s. Before the Enron deal and all. I mean, she's ridiculous. Super brilliant. Anyway. It's out there and you're gonna come across it. What was she complaining about? Feet swelling and numbness in her feet.
Oh, no.
It's out there. Don't be surprised. Don't go to the doctor. They don't get checked. They don't do all the things that we say they should do. Okay. Mitochondrial dysfunction. Clearly, if you're not getting glucose into the cell, then what does the cell have to do for energy? Alternative pathway. Are you gonna produce as much ATP? No, so what's gonna happen to your mitochondria? They're gonna become dysfunctional, yes, and ultimately destroy the cell. About it. Okay, and when you start having cell destruction, then what happens? Yeah, inflammation. What inflammation?
Always dance.
It's almost always right. Here's the question, here's the answer to your insulin resistance. Okay, so, you're not getting, the insulin's not allowing glucose to go into the cell. Is it all or nothing? No, there's some that gets in, it's just a reduction. So first off, are these patients going to end up typically in DKA? No, because it's not a complete lack, okay? It's gonna lead to decreased insulin production, okay? There are insulin antagonists that are in the plasma. And there is impaired response in the target tissues. So after a while, they're kind of like, oh, do I know you? Yeah, no, they're just not gonna respond the same way. Okay, and so this also is, there's an interplay between insulin, your growth hormone, and your growth hormone, your insulin like growth factor 1, IGF-1. Okay, and so all these kind of play together. And so when you look at the fed state. This should all be like very synchronized, your growth hormone, which we'll talk about. You know, it plays into your insulin-like growth factor as produced by the liver. This is a major player in allowing the effects of insulin, okay? Now, in the fasting state, keep in mind, you've got glucagon, you've got your glucocorticoids, okay, which can increase your glucose levels, and your catecholamines. They all work to prevent hypoglycemia. That's normal, okay? That's your normal state. Okay? If you have an excess of any of these, as in stress hormones, it's going to contribute to insulin resistance. It's going to contribute to that insulin resistance. It's going to make it, it's kind of overly stimulated, and it's going to resist insulin. Plus, your catecholamines are designed to resist insulin. They fight insulin. Yes, Ryan.
How do you know the chicken breast, like, if it's the hypertension and the other comorbidities that are causing an excess of glucocorticoids, catecholamines, or if it's the diabetes causing the other ones?
Well, you know, a very detailed patient history will kind of lean you in the right direction. But at this point, depending on where you see your patient, it doesn't really matter. Because, again, you have to treat your patient based on how that patient presents to you. You're still gonna have to address the hypertension. You're still gonna have to address the diabetes. It's just a matter of timing, duration, things like that. Now,
Like a cascade, all of them.
absolutely. That's why diabetes is like the perfect storm. Okay? Because you can't always tell. You can't. But they're always, that's the whole metabolic syndrome. Even before they're diagnosed as diabetic, that's the metabolic syndrome. Think about it. 2 of the 3, hypertension, increased waist circumference, there's your obesity, that leads to your adipose tissues, your high triglycerides, and that's why you screen for all of these things, because they all become important at that stage, and you have to address each one.
You probably see those.
Yeah. Well, a lot of times, yeah. In type 2s. You got it. Yeah. You're welcome. And, you know, of course, your 3 main insulin sensitive organs outside of the pancreas are your skeletal muscle, your adipose tissue, and your liver. So if insulin can't get glucose into the cells, think about how your patients are going to present. Weakness, muscle weakness, fatigue. Okay. And that's one of the biggest complaints. Plus, they're gonna be at the obesity. If you look specifically at what's going on in these, you know, extra pancreatic organs, skeletal muscle. Here's what the insulin does. Stimulating your glycogen synthesis, taking it glucose, storing it where then it can be utilized. And so physical activity is going to improve this. Adipose tissue. It's actually metabolic tissue. and it has a function. It's just that it's like anything else, if it shifts one side of the spectrum versus the other, neither are very good. So you want to kind of stay right in the median where you have a good amount of body fat that is supposed to be normal. Okay, and so, all this I've already gone over. In the liver, insulin regulates your glucose, your production, gluconeogenesis, as well as utilization and glycogenolysis. You know, insulin resistance is gonna impair that. Inability to store the glucose, okay? It's not gonna suppress glucose production. So we said if the insulin inhibits glycogenolysis, the liver is going to keep breaking it down. Okay, it's not going to store glucose as glycogen. It's going to break it down. Okay, and it's going to increase the production of lipids, especially your VLDLs, as a result of the increase in triglycerides. And so let's talk a minute about what happens when you have those high glucose levels. Okay. It's had multiple names and acronyms over the years. And so the more common one is hyperglycemic hyperosmolar non-ketotic syndrome. It's been called HONK, hyperosmolar non-ketosis. It's been called, and you'll hear it, HNS only. But it's very descriptive if you spell it all out. So it's hyperglycemia, which makes sense, right? Insulin can't get the glucose into the cells, so you're gonna have high glucose levels in the blood. Hyperglycemia. Hyperosmolar. What did we talk about last week with glucose? Big molecule. Okay, it's gonna have a fairly good osmotic draw if it's in higher than normal levels. Okay, if your normal glucose is under 100 and you're 250, think about the osmolar load that's going to have. The osmotic effect. Okay. So the effect in this case, okay, is number one, as it goes, and I'm going to go through this again because I know that a couple people had issues with this, as the glomerulus filters and glucose passes through, proximal tubule can't reabsorb enough. So but that's active transport, right? Active transport out of the lumen of the nephron. Okay, and so a bunch of the glucose stays in the nephron tubule through the loop of Henle. So what is that going to do to the concentration in the loop of Henle? Increase it, right? It's going to increase the osmolality. So what net effect is that going to have on water? Hold it in the tubule, okay, for excretion. Okay, so water goes out with the glucose. So you have glucosuria, you got water in there, and a lot of that water would have normally been reabsorbed along with the sodium, but it's spilling out. Sodium's still being reabsorbed through active transport, but now we're spilling out water. So what's going to happen to your concentration levels? What's going to happen to your urine? Dilute or concentrated? Dilute. What's going to happen to your blood? Concentrated. Well, you guys are good. Okay, so in effect, it's a dehydrated state, hyperosmolar. Okay, that's going to trigger your hypothalamus to say you're thirsty. Drink. Okay, drink water. Okay, instead they go for the cranberry juice, the orange juice. Notorious. Thirsty. Let me get a big gulp. drink 3 more sodas. They will-
So they'll be hypernatremic?
Here's the weird thing. So give me a second, because I'm walking you through this, all right? So in order to try to maintain osmolality within the bloodstream, what does the body try to do in dehydrated states? Draw water from
Intravascular. space.
extravascular spaces, including the interstitium and the cells, right? So water comes in and it actually causes, now the osmolality is still high because of the high glucose levels. But it's relative. There is, when you have hyperglycemia, you're going to have a relative hyponatremia. That's what correct. You're gonna have a relative hyponatremia. And there's actually a correction formula in the case of high hyperglycemia, so that you don't try to correct the sodium level because of that net effect. Right? It's just like any other dehydration. It's the hypothalamus perceives hyperosmolality as dehydration. The body's gonna draw, the water's gonna, it's gonna make you thirsty. That's the thirst reflex. Water itself will go from area of lower concentration to areas of higher concentration. So it's gonna migrate from the interstitium and the cells, okay? When you go to fix this, okay, how are you going to treat your patient? How are you gonna treat your patient? Comes in confused, disoriented. You're gonna give them fluids, but what are you gonna give them? Probably normal saline, okay? How fast are you gonna give it to them? Slow. Why slow?
Because it has to shift back.
Right, because of the shift going back. So once you start to normalize in the vasculature, water's now gonna go out, back into the interstitium and into the various cells. If you do it too fast, cerebral edema. Closed space, you only have so much room. We have to do this very strategically over time so as to prevent cerebral edema,
Even with the normal saline.
even with normal saline. With functioning kidneys. Okay? All right. All right, so we said that type 2 hyperglycemia is typically not all or nothing. So are you gonna have ketoacidosis? No, that's why it's called non-ketotic syndrome. So you're not gonna use fatty acids for your alternative fuel source, right? You're going to still be using some glucose. You might have some ketone, but it's not gonna be to the extent that you have with type 1 diabetes. Right? And so there's really no, and usually the kidneys can filter that. So you're not gonna have a buildup of keto acids. Okay? And so unfortunately, you know, this is not a very good place to be in, because you can see where it is a delicate situation to try to fix it when they get to this point between hydration and worrying and bringing the sugar down and, you know, worrying about cerebral edema and things like that. You have a question, Emily?
Yeah, the patients that come with this and they don't have diabetes, are you going to give them insulin?
It's a good question. It's a good question. What do y'all think? If they come in with hyperglycemia and hyperosmolar, non-ketotic syndrome, Are you gonna give them insulin? Yeah. Sure. Okay, so this is a condition that we see it with type two diabetics, but we also see it in other conditions like, and yes, it can be very, very severe in your older patients with type two diabetes. More so, they have a little less rebound power. They don't have the flexibility that younger patients have. And I use those terms relatively. Okay, sometimes you can see this even in young type one diabetics. But you can also see it in patients who don't have diabetes, if they have like a severe burn or, you know, who are getting total parenteral nutrition or after dialysis or certain drugs, things like that. So there are a few other conditions where this can occur. Bottom line is you still have to treat the hypoglycemia. So the best way is to get it into the cells and facilitate it into the cells, also hydrating your patient, okay? Yes, Ruth. It depends on where the patient is in the process. As I said, like, you know, if their glucose is 250, it's probably not, because it occurs over a chronic period of time. We're not talking about them having this syndrome at like a glucose of 250. Eliza, what's the highest non-type or a type two diabetic glucose that you've seen?
Like when it just doesn't give you a number, it just says high and I'm
When the lab comes back, okay. We've seen
like
high ones.
7 something, I don't know,
Anybody else?
really spicy.
900, 1200. Yes. 900, 800s, 900s, 1200, yeah. Really, really super high. Okay. Now, I mean, it could happen in the 600s too. But, it's very person dependent and it's kind of duration dependent, how long has this been going on? Okay, and so you kind of have to do all your other ancillary tests. If somebody is to that point of dehydration, essentially, okay, they're gonna have other like findings, like they're gonna have tenting of the skin, they're gonna have muscle weakness, severe muscle weakness. They're gonna have all these other manifestations, as opposed to just coming in and be like my girlfriend, you know, and be just like, you know, this is a, you know, she doesn't have this syndrome. Okay. They're very symptomatic. Thank you. Okay. Yeah. The prolonged, what we're talking about is this kind of, in this is a prolonged osmotic diuresis that's occurring. So the glucose, you're urinating, it's drawing the water out. This has been occurring for a period of time, okay? And so that's what this next bullet point's really about. It's how it initially affects the intravascular fluid levels, then the interstitial, and then the intracellular. So it's that whole continuum. Okay, so water loss is much greater than sodium loss at this point in time. Okay, because the water is going to the higher concentration in the nephron and it's being, you know, excreted in the urine. However, that's leaving behind sodium with a decreased amount of water and your glucose, which then is going to draw fluid in. Okay, so because it can, over a period of time, it can still lead to a hypernatremic, hypertonic dehydration. So you're going to rehydrate them. And initially, it's going to be with that 0.9 normal saline. And then after a while, you switch it over to 0.5. Okay, once you get it to a reasonable level, then you can switch it over to finish with more water, less sodium. Okay, this diagram is really kind of a complicated drawing of what is going on in HHS or HHNS. You start with your insulin deficiency up the top, okay? Okay, insulin deficiency, that's gonna lead to your decrease in glucose utilization, okay? Your gluconeogenesis, your counter-regulatory hormones are gonna stimulate gluconeogenesis. That's gonna increase your use of lipids and amino acids to make more glucose and increase the glucose even higher. Plus, break down your glycogen levels, all of which lead to hyperglycemia. Okay, that's going to lead to glucosuria, which creates the osmotic diuresis down here. Okay, yes, you're going to lose water, you're going to lose electrolytes, you're going to be losing some potassium. And yeah, depending on how much you're going, you can still lose some sodium. And so this creates a dehydrated state, hyperosmolality, and the dehydration itself is going to have an effect on the kidney, that the kidney is going to say, oh, it's already dehydrated, so it's going to shut down and vasoconstrict the afferent, okay, and so it's not going to put out as much once you're dehydrated, which then is going to even worsen the situation, okay, with glucose. So yeah, we absolutely have to treat with, insulin, okay, and fluids. All right, looking at some of that pathophysiology, it comes in macrovascular, microvascular, and neurologic forms. Okay, and so, macrovascular, large vessels of the heart, the brain, the legs. You understand the problems now, okay, and so, you know, say this, so essentially, okay, we talked about how all that inflammation, the endothelial dysfunction, is going to lead to damage, the glycosylation of these endothelial cells. And so, you know, we start to see all the different complications, even at an earlier age, because of the process and because of this constant state of inflammation. And regardless, normally women with estrogen tends to be cardioprotective. Well, they actually lose the cardioprotection. And so all that female protection is actually lost in your diabetic population. So any diabetic female presenting with chest pain or atypical chest pain or arm pain, you have to work up for cardiovascular and or TIA. So remember, these are large vessels of the brain, the heart, and the legs. It's a system. Okay, and essentially, if you have it in what chooses one place over the other is very patient specific. But if it's in one, you have to assume it's in the other places as well. Okay. The dyslipidemia that you can expect, high triglycerides makes sense. High LDLs, low HDLs. That's your dyslipidemia. You do not have to have high elevated total cholesterol to have dyslipidemia. Okay, so do your lipid panels and look at your fractions. Okay, and so that's going to promote, and once you start getting to that point, that's gonna promote the atherosclerosis. And then we talked about the endothelial dysfunction, reduced vasodilation because of nitric oxide, increased vasoconstriction because of bradykinin not balanced. Okay, there's also a prostaglandin inhibition that goes on there as well. And so that, and then your reactive oxygen species, and that's gonna create that atherogenic plaque. Your microvascular complications, we're looking at the eyes, the kidneys, the nerves. Okay, so it's blood supply even affecting the nerves. Okay, there's myelin cells, there's that, you know, the cells that produce the myelin sheaths and protect it and nourish those nerves. Okay, and so all the capillaries throughout the body can be affected. Okay, and so because these tissues are permeable to glucose entering the cells without insulin, this is how that glycosylation occurs, okay, and leading to permanent dysfunction. Okay. This just kind of walks you through that process as well. Okay. And so, you know, we're talking about small vessels now, high glucose levels. Okay, it's going to, you're gonna still have glucose going in, high levels of intracellular glucose. Okay, that's gonna affect your mitochondrial electron transport and oxygen-free radicals, and then gonna lead to all kinds of problems and tissue damage. Okay, looking at your normal retina on the left and your diabetic retina on the right. And you can see the effect that it has on those blood vessels with hemorrhaging. Yeah. Here's a good question. I'll get to that in a minute, but this is looking at the glomerulus in your kidney, each nephron, okay, and the difference between normal and normal function, and when you have high levels of glucose, okay, and it can lead to protein leakage as well over time because of these large molecules going through the filter can damage that glomerulus and lead to protein loss as well, and leads to nephrotic, can lead to the nephrotic syndrome just because of damage. And then the nerves, again, in the neuropathy, how, you know, without appropriate blood flow through the vessels, as these vessels, the endothelial cells become damaged, they're gonna weaken, you can't supply the nerves are going to wither, shrivel, and that's gonna lead to your neuropathy. Okay, so before we take a break, I have one question for you. Okay. So when you have a patient who presents with hyperglycemia, one of the, whether it's type 1 or type 2, one of the complaints is blurred vision, right? Did you hear about that from Dr. Hendricks? Blurred vision, polyuria. Okay, what's causing the blurred vision? What do you think is causing the blurred vision? I want you to put your thinking caps on. What's causing the blurred vision? Probably trying to work your way. Hi, Jacqueline.
Does it have to do with, like glucose getting into the muscles of the eye that are like focusing? No,
You know, I like your thought process. I do, I really do like your thought process. You're really, but it's before that part. If it's before that. but you're on the right track. You're sort of on the right track. How does that feel?
The glucose and the fluid.
Uh-huh.
The floaters.
Not floaters, but glucose in the fluid. And what fluid?
That's what I was. Like the
aqueous?
Uh-huh.
The aqueous or.
Yeah.
The vitreous.
Uh-huh. Right, remember that, okay, so if you have a hyperosmolar state and you've got all this glucose circulating, okay, it extravasates into the interstitium. Okay, it evens out, it goes through those capillary walls. And so your eyes are kind of, remember, they're, it's not a connected network, they're terminal vessels. And so what goes in and leaks out is now going to be in your eyes, into those tissue, into those structures, your aqueous humor, your vitreous humor. It's going to be high glucose level. It could be hyperosmolar. It's going to be thicker, more viscous. Does anybody in here? I know, well, some people have pushed D50. What's it like?
They gave me a workout.
It's like pushing king syrup, you know, pancake syrup, the king thick stuff, the real thick stuff. Try not push it through a syringe, okay? It's really thick, right? It's sugary. It's a lot of glucose in there. Okay? This is what happens. And so it becomes a much thicker fluid, which then distorts the vision and refraction of what's going through to the retina. Yes, Eliza.
Will that go away relatively quickly once you?
It takes time, but it does go away, yes. Mhm. Yes. All right, see you at 4:00. We got a lot to cover. Quick break. For, you know, or hormone function and hormone resistance. Those are what cause most endocrine problems. Okay, so you've got to always think in terms of what's the pathway? Okay, what's the pathway? And then what's the net result? Okay? So hypofunction can be anything from absence or destruction of a gland or just impaired function. And that could be something as simple as an enzyme. Okay, hyperfunction is typically an adenoma or hyperplasia, but you always got to think ectopic secreting tumor, paraneoplastic syndrome, okay? Your hormone resistance, it's receptor deficits. Now, that can be, you know, either absent or it could be defective, okay? And you've seen the defective in your type 2 diabetics. Remember your primary, secondary, tertiary. Okay? Primary always refers to the target organ or the organ that produces the hormone in question. Okay? Primary always refers to the target organ or essentially the organ that produces the hormone in question. Secondary is pituitary. If it's under pituitary control. Tertiary would be hypothalamic if it's under hypothalamic control. Not all hormones follow that as far as have that tertiary pattern. Okay. Parathyroid. It does its own thing, right? It by itself senses calcium levels. It's not under pituitary or hypothalamic control. Your pancreas. Okay. How about growth hormone? Tell me about growth hormone. Primary would be pituitary. Is there anything else? Hypothalamus. Okay. Produces. A growth hormone releasing factor, or whatever you want to produces somatostatin. All right, so we're gonna start with pituitary and growth disorders. Hey, whenever you're thinking about hypothalamic or pituitary function, you gotta start with the appropriate blood or plasma level, okay? So you're gonna test your various hormone levels, okay, depending on what your patient is presenting with. Okay, so remember which hormones come from which part, okay? You add imaging as indicated. MRI is much better. Why? Soft tissue, and it's very, very small. You can take really like super, many pictures, super small area, okay? And then we can always do subsequent stimulation or suppression tests. When do you use stimulation tests? When you have hypofunction, and you use suppression tests when you have hyper. You see, you do remember stuff. This is great, okay. So, all right.
Some of you.
They can be primary or secondary. They can be functional or non-functional. They can be micro or macro. They can be benign and malignant. Okay. Then we can further subdivide by cell type. So a prolactinoma versus a ACTH secreting tumor, okay, adenoma. And again, tumor just means a growth, a new growth. So it doesn't tell you whether it's benign or malignant. So some of your different adenomas and the frequencies. Okay. Pretty interesting, right? Your lactotrophic is, or also called a prolactinoma. That makes up the majority of them. Okay. As far as hypopituitarism, this can be congenital or acquired. Okay. If it's pan hypopituitarism, then you're gonna see effects of all of those, all 6 hormones, right? You're gonna see hypofunction. If it's selective, okay, then what is it selective to? Okay. If it's acquired, it's typically a gradual process, but sometimes it can present acutely. Anybody want to guess why? Couple reasons. I'll come back to it. All right. If you have hypopituitarism, yes, it can be associated with high morbidity or mortality, with an ACTH hypo secretion being the most critical. Okay. Why do you think that is?
Affects your cortisol level.
Yeah, affects your cortisol. That's one of our stress hormones. That's our fight or flight. That's, it's so many different things. Yes. Okay. Typically you need about 75% destruction for symptoms to occur. Okay. And these patients present with either like just being chronically unfit, again, the weakness, the fatigue, think about the different hormones. Okay, loss of appetite, poor sexual function. That's what all these hormones do, right? Then cold intolerance because of the thyroid. And so, yeah, depending on what hormones are released, that's what you have to replace in hypopituitarism. That extra T in there. All right, so what are the causes? Tumors, mass lesions. Okay. And there's a list there of patients who've had pituitary surgery or radiation for a particular reason that can damage it. Other infiltrative lesions or infections. Pituitary infarction. Okay, and so, if you have a loss of blood supply. Pituitary apoplexy, which is a sudden hemorrhage into the pituitary. Well, that's not gonna be good. Various genetic diseases, they tend to be pretty rare. Empty cell syndrome, where the pituitary just doesn't develop properly and fill up the, cella turcica. And other, even hypothalamic disorders, so tumors or mass lesions that affect the, hypothalamus. Again, if the hypothalamus is producing all these releasing and inhibitory hormones, if that's the primary, or if that's your tertiary level, it's gotta stimulate the pituitary. Okay, so what are some of the clinical manifestations of pituitary tumors? Okay, well, this is, a very tiny, actually, relatively speaking, a small organ in a very confined space that sits right by the optic chiasm in the brain. Pure anatomy here. Okay? So most of your clinical manifestations, like your acute presentations, often have to do with a macroadenoma. Okay, it's greater than 10 millimeters. Bigger tumor in this enclosed space that then either stretches the dura, impinges on the bone. It can lead to breakdown of the bone, or impingement of that optic tract. Okay, if it grows big enough and impinges that optic chiasm, then they're gonna have visual field defects. The classic presentation of that is to have a bitemporal hemianopia. And this has to do with where it's going to sit right on that optic chiasm and prevent the flow from the temporal region from both eyes over to the one side. Okay. If it's right in the middle, then you can have bitemporal. There can also be cranial nerve palsies, especially involving the eye. The optic nerve can be involved. Any of the eye cranial nerves 3, 4, and 6. Okay, as well as 2. So diplopia can occur. They can have palsies with your EOMs. Okay. And then they can actually, if the tumor extends down far enough and puts pressure on that bone, it can lead to bone erosion. And they can actually have CSF rhinorrhea. And so as the tumors expand, the more tissues are going to be damaged and more hormonal loss is going to occur. So let's talk about some of the growth and growth hormone disorders. Okay, all normal growth in the body requires growth hormone as well as insulin, and your thyroid hormone as well as androgens. So these all work together for growth, especially long bone growth. Your growth hormone is called somatotropin. Okay, and so you may see it as either on an exam. There was once thought that these levels would only be high in children because children are growing and that adults didn't have as much. But new research has shown that the adult levels are as high as that for growing children. The effects are just different. And growth hormone just doesn't cause bones to elongate. it actually facilitates how fast proteins are produced. So every time we eat, this is that kind of integral, coordination between growth hormone and insulin-like growth factor, and even your androgens, because it is gonna help with protein synthesis. It actually causes the use of fatty acids for energy, which can promote, peripheral insulin resistance. And, so it uses those, insulin-like growth factors. It requires specific binding protein. And, when we see secretion of it is in the hypoglycemic, state. Okay, during fasting, during starvation, when there's increased blood levels of amino acids. Okay, actually, growth hormone secretion causes these, my bad. Growth hormone actually causes all of these. Inhibition is gonna lead to increased glucose levels and levels of free fatty acids, etc. Okay, so growth hormone, insulin, all work together. And so, if you look at it, the anti-insulin effects are on your right. Okay. And what growth hormone does is on the left. So this is all a review from AMS. And so the importance of this of growth hormone with bone growth, with muscles, muscle growth, muscle function, and for just overall protein synthesis, critically important. Okay. Now, some of the patho, short stature in children, is not always, as you probably learned, I don't know, you covered this in Pete's, yeah, you should have because you got your final. So it's not always, sorry. Hold on, it's not always caused by a growth hormone deficit, but here are the keys. Okay, so take note. Usually the height's less than the 3rd percentile. This is the importance of your growth curves. Okay, and it's often associated with other physical findings. Okay. And so I'll talk about that a little bit more. So other causes, it could be endocrine in nature, it could be a genetic disorder. So there's a whole host of things that can cause short stature. Of course, you're gonna evaluate, you're gonna look at everything, if, in most cases, you're gonna give recombinant growth hormone. If it's truly a hormone issue. Okay. There are familial short stature, which is not something that we treat. Okay, and sometimes it's just genetic. You've got to look at the size of the parents. And sometimes there's constitutional delay, and that can be caused by a whole host of things, including nutrition. And that doesn't necessarily mean that there's a disease state. It's more supportive care. And there is a condition, and I don't know if Professor Rogers talked about it or not, called psychosocial dwarfism. Did she talk about this at all? This is actually, I found this very fascinating, in that in certain children who lack love and support and the emotional environment, and it's usually one child out of a group of many that kind of gets the neglect. And these children tend to be very small. They tend to have constitutional delay, little pot bellies, and very, very frail looking. And if you put them in a loving, kind, emotionally supportive environment, then their functional hypopituitarism resolves, and they actually don't need any kind of treatment other than to be loved. Fascinating, fascinating. Yeah, it's pathetic though, and when you think about it. It really is a sad. But you've got to look at the families too. All right, so if there is a hormone deficiency, it's not just short stature. Look at their sub-Q fat, okay? It's often increased in the abdominal area. And they often have, immature facial features, like maybe some flattening of the nasal bridge. Their teeth don't come in at the normal expected time, so they have delay in their, dental eruption. They have some of that frontal bossing that we've talked about in police anemia. So you may see that as well. And there are a lot of different causes for that, including pituitary tumors. It can be idiopathic. And so if, in fact, your growth hormone levels are deficient, then we're going to treat it with growth hormone. There's a specific syndrome called Laron syndrome, and it's not the growth hormone proper. It's not due to hypopituitarism. It's actually due to the receptors. And so there are defective growth hormone receptors that aren't allowed to. And so we actually have to treat them with an insulin, IGF-1. We have to treat them differently. In adults, there are two variations. And so it's either a persistence from childhood or it's new onset, and usually due to some type of radiation to the head or treatment or something like that. Sometimes aging alone can lead to hypopituitarism and a decrease in growth hormone. And so there's really no consensus on treatment of adults at this point in time. All right, tall stature and growth. Okay, this is, in the other end of the spectrum where the height's greater than the 97th percentile. And, again, there is familial tall stature, so you have to look at that. And sometimes people just are a little bit ahead of the curve in their growth. It doesn't necessarily mean that they're diseased. Okay. Now, there are some genetic or chromosomal syndromes, including Marfan's, Klinefelter's, Fragile X, and Beckwith-Wiedemann syndrome. So, this gets into some of the genetic testing. And so this is where, if this is genetic and it's the growth, excess growth hormone is before closure of the growth plates. This is where you're going to see gigantism because of the excess growth hormone. And as far as the adults, it's after the growth plates have closed. And so you're going to see the signs and symptoms of acromegaly, which have to do with increased sub-Q tissues, thickening of some of these tissues. Some of your flat bones will become more pronounced, like in the jaw with the protruding jaw, the broader forehead, a coarsening of the features, and so the excess hormone is going to bind to your liver receptors. That's going to lead to an increase in IGF-1, which then will stimulate the growth in those peripheral tissues. Okay, and so and it affects all organs, all tissues. The ones that we see externally are relatively obvious. What we see internally is not so obvious, but you've got to consider that it's affecting all organs, including the heart. And so some of the effects here is growth hormone. The excess is going to lead to increased lipolysis, which is going to increase your free fatty acids, shifting your metabolic metabolic, source into, result in increase in ketones, a decrease in glucose metabolism, high insulin production, and ultimately beta cell burnout, which leads to type 2 diabetes in these patients. But you can see all the different organs that are affected. And it's not just the facial features and the large increased hand or foot size. So causes lots of problems. Okay, moral growth hormone, precocious puberty. Okay, you know, this just has to do with an early activation of not just growth hormone, sorry, pituitary hormone, pituitary. And this has to do with early activation of your HPA axis. And so sexual characteristics are going to become more prominent. It's 8 years in females, 9 in males. Even though we're seeing a shift from, you know, older to younger, they're still sticking with 8 and 9 to make sure that they capture people who may have precocious puberty. And so this can be either idiopathic or it can be caused by disease affecting these organs, including the pituitary. And they can be benign or malignant. So you kind of have to identify it first and then figure out whether it's a tumor or not. All right, moving on to thyroid. Thyroid, you covered this today, I presume. Okay, so thyroid's pretty interesting. If you remember from AMS, hopefully you do, but if not, very quick review. You know where it's located. Inside these little follicles is where all the action occurs. And of course, my thing is not working again. But up there in that lumen of the follicle is where your thyroglobulin is. So there's your thyroid, your lumen, right? And this whole reaction that takes place, okay, that produces your T3 and T4. And so iodine gets transported into the follicle cells, across the other barriers, like across into that lumen, where all that colloid is containing your thyroglobulin. You get iodination, and it makes both mono and di molecules. If you have two dyes together, diiodinated, that makes your tetra or your T4. If you have a mono with a di, that's going to give you your T3, your triiodo. Okay, so once they're formed, then it's snatched back out of the lumen, then back across the cell membrane where it gets released into the blood. All has to do with your iodinization. Try saying that. Okay. Thyroperoxidase is the enzyme that iodinizes your thyroglobulin. Okay. TPO becomes important in your Hashimoto's thyroiditis because you have antibodies against TPO. Okay, and so T3 more potent, short half-life 1 day. T4 more stable, longer half-life 7 days. It can be converted to T3 when needed. They require protein transport molecules. Your thyroxine binding globulin is the main molecule. However, albumin, a prealbumin, and they are alternatives. So we can utilize those for transport as well. And the amount of circulating T4 that's bound, that becomes a reservoir for when our body needs it in times of stress and growth and things like that. So if you look at this whole chemical and biologic process, there are multiple pathways where you can have defects occur. Okay, you can have problems with your binding and transport proteins. You can have, so any disease that affects the liver is gonna affect your liver's production of protein and protein transport molecules. Okay, and you can have altered function of your thyroxine binding globulin. And you can have drug alterations in binding, so ones like phenytoin and diazepam, even aspirins that essentially have a stronger predilection for albumin. Okay, and so can bump it and compete for those binding sites and transport sites. You can have protein defects. Okay, and so all of these can lead to problems with the ability for your thyroid hormone to be normal. It is ultimately under hypothalamic control. So this is one of your tertiary syndromes, okay? So the thyroid would be level what?
One.
Primary, right? Okay, pituitary secondary, and your hypothalamus is tertiary. Okay, you know what your actions are of thyroid hormone. And it's necessary for metabolism in every cell of the human body. Okay. And so it itself is going to increase metabolism with protein synthesis. It's so important for growth and development, especially neural development. That's why it's so important in children and diagnosing congenital hypothyroidism. Okay, you can see the effects when the different organ systems here. Okay. And as far as how it manifests, this is a great summary slide of what you expect with hypothyroidism versus hyper. When do you have alterations? So hypo or hyper, and you can have with or without a goiter. Okay, so a goiter is just an enlarged thyroid, okay? That's all goiter means. It doesn't tell you anything about function, whether it's normal function, hyperfunction, or hypofunction. It just means an enlarged thyroid. Okay, and so when you look at it, it can be diffusely enlarged, or it can be nodular, it can be very lumpy. You can see this one, and how would you describe that one? Nodular, okay. How big it gets has to often do with how long the patient's been diseased. And the goiter itself can be either toxic or non-toxic. So a goiter in and of itself tells you nothing about function. Okay. However, as these goiters get bigger and bigger and bigger, you have to consider all of the other structures that are in the anterior neck. So you've got to think about potentially compressing the airway, okay? Compressing your venous lines. Okay. If it extends down into the chest, it can lead to SVC syndrome. So it can compress the esophagus and lead to swallowing issues. So physically, anatomically, these large goiters, regardless of the thyroid function, can have physical effects, much like the pituitary. So hypothyroidism, congenital or acquired, okay? If it's congenital, and you know, there's a lot of countries now are instituting, you know, screening for this to prevent it, because initially In utero, the baby's getting all of mom's thyroid hormones. Okay, so you're not gonna notice this right off the bat when they are born. Okay, because those thyroid hormones are gonna cross the placenta. And so what's gonna happen is over time, mom's is gonna get depleted. If the baby's not producing enough, then they're gonna start to have changes in their growth pattern, as well as their mental neurologic development. Okay, and so we're talking about the brain, even in those first 6 months of life. Okay? And it can be due to a congenital lack of the thyroid. It can be due to abnormal synthesis of the hormone. It could be at the pituitary level, or it can be at the hypothalamic level. And so, or it can be transient. As far as acquired, okay, again, this can come at any of the 3 levels. Primary is the most common, significantly more common than the other 2. Okay, and with the hypothalamus being the least common. Okay. Always get your medical history, because certain drugs, like lithium, can block hormone synthesis, which means that it can actually lead to goiter and hypothyroid condition. Okay, and lithium and that whole scenario is always a pants question. I'll tell you that right now. Always a pants question. Large amounts of iodine. If you have excessive iodine, it can actually block hormone production. So by down regulating those receptors, there can be an iodine deficiency. Not so much in this country, but in countries worldwide, iodine deficiency is probably the #1 cause. And there can be different causes of thyroiditis. And so Hashimoto's is a very specific autoimmune where the autoantibodies are actually attacking the follicular cells. I think it actually has a target on, or there's one that targets TPO, and I can't remember which one it is off the top of my head. Okay. There's your clinical manifestations, which you've learned. Yes.
For the large amounts of iodine.
Mhm.
But also iodine. So would it be like somebody has large amounts of iodine because they're on like amiodarone, or they get too much contrast, and then that causes down regulation, and then their body gets rid of that stuff, so then they have hormone production down after that, because then they don't have as much iodine later?
Yeah, we don't know the exact mechanisms. It's like, we know that excessive amounts can cause down regulation of any of these receptors. Okay, and so indicate, these are all kind of a little bit different. I think like the excessive iodine contrast, like you do iodine study after iodine study after iodine study, repeat, all these nice CTs that the emergency departments like to run on everybody every time they come in, you know, and you give IV contrast, well, it can actually completely shut this down at some point in time. Okay, realize that it is a radioisotope. And it is, and so it can actually cause damage to those receptors and shut down essentially the receptors, so that no iodine is getting into those follicular cells. As far as, you know, people who are taking like kelp tabs and like long term, I think it might be a little bit different as far as it's just a total down regulation as opposed to maybe a toxicity. They're just different mechanisms. But overall, it's gonna block, it's gonna keep the iodine from getting in and producing the hormone. So if you think about hypothyroid, think about a hypo metabolic state where everything slows down. Okay, so slower metabolism, lower body temperatures. However, sorry, that's hyper. I'm going the wrong way. Hypo. So hypo, okay, is slow heart rate, cold intolerance, weight gain, the peripheral edema, the muscle weakness that again, metabolism, muscle cells aren't metabolizing, anovulatory menstrual cycles. But the mixed edema has to do with a glycoprotein, that actually gets produced and stored in these tissues. And so it's a non-pitting edema and it gets behind the eye. And we'll talk about Graves' disease in the, with that. But mixed edema is this other kind of, it just, all this edema and it's non-pitting. And so, it kind of, it gets everywhere, including these eye sockets, and, they lose their hair because of those, you know, those cells are rapidly reproducing while metabolism is going to slow down. So, and then you get the edema in the vocal cord, like in the neck and in the vocal cord areas, what's going to cause the deepening of the voice. Okay. Hyperthyroidism is thyroid toxicosis. Thyroid storm is an exaggerated version of that. It's a thyroid crisis where it's very fulminant all at once. And so think about everything being hypermetabolic, okay? High heart rate, sweating, heat intolerance, high metabolic activity. And high metabolic activity is going to produce a lot of waste. Okay, and these patients can be hungry, they're eating a lot, but they're losing weight. And so Graves' disease, very common. You can see there are other causes of it as well. And yes, excess iodine can lead to it. So all the manifestations are due to the increase in oxygen consumption and metabolic fuels that then lead to lots of byproduct, but it's a lot of energy, a lot of ATP production, and it's going to stimulate your sympathetic nervous system. So think about all the signs and symptoms of sympathetic stimulation, beta 1, beta 2, your alpha 1. And so Graves' disease specifically, okay, is hyperthyroidism. You've got a goiter, and some patients will have a significant ophthalmopathy. Okay, and so this is autoimmune, and it's unique in that the antibodies are essentially agonists. The antibodies that are produced are agonists for the TSH receptors. So they don't bind to the receptors and destroy them. They bind to the receptors and stimulate them as if TSH was there. Okay, and so it's going to cause all this excess production of T3 and T4. Well, T3 and T4, what's your TSH level going to be? What's your TSH level going to be? Low, very low, right? Exactly. So that's one of the ways you tell the difference between a Graves' disease and other causes of hyperthyroidism. So yes, Erin.
So in primary hypothyroidism, you'll have an increase in TSH, but in a tertiary type of illness, for hypothyroidism, you have a decrease.
Okay, so we're going back to hypothyroidism. All right, so in primary hypothyroidism, you will have an increase in TSH, yes. Because it's stimulating. And yes, it can cause hyperplasia and a goiter to occur. However, if there's a problem elsewhere and it can't manufacture T3 and T4, you're just gonna end up with that hyperplasia, that overstimulation. However, it's not producing T3 and T4, so you're gonna hypothyroid. If it's tertiary, okay, then your TSH levels are going to be low. If it's secondary, your TSH levels are gonna be low. If it's hypothalamic tertiary, your TSH levels are gonna be low. And your T3, T4 are gonna be low. Yep. You're welcome. So Graves, back to Graves, stimulation. So these antibodies are going to then stimulate, they're gonna be agonists to these receptors and stimulating the production. And so in Graves, your TSH levels are gonna be low, but your T3, T4 levels are gonna be high. These patients are gonna have signs and symptoms of hyper. About a third of the patients will develop that ophthalmopathy, which has an accumulation of T lymphocytes that are in there. And so it occurs in both the follicles of the thyroid as well as in the fibroblasts of the orbits. And they are going to then secrete cytokines, your T cells, those T cells will secrete cytokines that then cause this inflammatory reaction. And as that inflammation gets worse and worse, it can cause tethering of the muscles of the eye, of the optic nerve, and it can ultimately lead to blindness. And as those eyes, or all that inflammation behind the eye in the orbit, push that eyeball and it becomes like kind of pushing it out, now the eyelids won't close. And when the eyelids don't close, then the corneas are at risk of drying out and becoming ulcerated and things like that. So yeah, it's not a fun thing to have. But it's the inflammation will actually lead to destruction of the structures, the nerves, etc., behind the eye. Okay. Thyroid storm. I saw one patient in my lifetime and I wasn't sure what it was, but I'll never forget it ever again. And it was a 26-year-old male who came in full thyroid storm. And I'm like, he's like, I just feel like I can't sit still. I feel like I can't. I mean, he was like, he was hyperthermic, tachycardic, like in the 140s. And like, he literally, and I'm just like, I thought he was on coke or something, you know. But I'll never forget it now. It was fascinating. It was really fascinating. Terrible for him. And, but he had all of the effects. He had all of the effects, and it can be fatal. So we beta blockaded him and got him admitted to the ICU. All right, we got 10 minutes to cover the adrenal. It's not bad. All right. Okay. I will tell you that this diagram to the right is very, very important. When you think, because the adrenal gland can be so confusing, can it? Right, okay. So, you know, the medulla is what produces your epinephrine, norepinephrine. Our bodies can live without the adrenal medulla because our parasympathetic nervous system produces it too. Okay, so yes, it is secreted and it's important in fight or flight. However, our sympathetic nervous system can produce it. So that's not the big thing. The cortex is what is the bigger thing, that's the bigger issue. Okay, and so you have your three different layers of the cortex. And so they all, essentially, all of the hormones that are produced, all three hormones, there's over 30 hormones produced in the adrenal cortex. Okay, we're only really focusing on the major ones. So androstenedione, which are your androgens, your cortisol, and your aldosterone. Okay, they all come from the same molecule. Okay, they all start with the same molecule, and it's just a matter of which pathway it takes, which enzyme pathway. And if we have enzyme deficiencies, it depends which deficiency is there that acts at which level as to what ends up getting produced or not produced. Okay? So essentially, if it gets stimulated, if you lack, and the green is supposed to be your 21 hydroxylase and your blue is your 11 beta hydroxylase. Essentially, if you lack this enzyme, both of these pathways are going to shift over and only produce androgens. Okay, you all see that? So if you lack this enzyme, you have a complete deficiency of this enzyme, it's going to shift over. And this is where you're going to be all androgens. And you're going to be aldosterone deficient and cortisol deficient. Yeah. And if it's 11 beta hydroxylase, and this one has the wider spectrum, it's still going to shift over in this direction. However, this one has, it's not all or nothing. As I continue to say, it's not always all or nothing. There's often a spectrum of how much is there. So if you're deficient versus deficient doesn't mean absent. Deficient means you don't have enough, but it's not absent. So you're still going to have some, but not enough, which is why you have these broad spectrums of disease. Yes, Karen. Well, what's your question?
So like, are there more?
Yes. Yes, yes. So in this case, you're gonna see what kind of presentation. For androgen. Bingo, you got it. Okay, which is why you have this broad spectrum in congenital adrenal hyperplasia. Okay, congenital adrenal hyperplasia depends on which hormone is deficient, where this gets shifted, and how significantly the patient is affected. Okay, and so that's what we're going to talk about. Okay, so yes, 30 different hormones. Your main classes are there. Aldosterone, the main carrier molecule is albumin. Your cortisol, your main is a corticosteroid binding globulin. However, some albumin is your carrier molecule. Yeah, these are cholesterol hormones, so they need a protein molecule to transport them. And your androgens from the adrenal gland are DHEA, sulfate, okay? And this is mostly albumin. So as you can see, albumin is so important in all of these, and so many of these hormones and transportation. It is under control of the pituitary and hypothalamus. It's secreted in an unbound state. These are secreted enough. They get bound, and then the liver metabolizes them and or conjugates them. And then they can be eliminated in bile or urine, depending on what's not used or used. Okay, so your feedback mechanism Okay, once your cortisol is produced, if we're looking at cortisol, okay, once your cortisol levels go up, then your releasing factors and your ACTH levels going to go down. Okay, and so cortisol, stress response, increased glucose for fight or flight, also stimulates your sympathetic nervous system. So it does provide some stimulation there, and it does have some control on the inflammatory response. This is all the actions of cortisol. These are, this is terrible English grammar. These are all the actions of cortisol. Most of these anti-inflammatory actions are based on pharmacologic levels of the drug, okay, not physiologic levels. Okay. Note that cortisol, which we give steroids all the time, okay, does have an effect on the emotions and can have everything from behavioral issues to full-blown psychosis at pharmacologic levels. So steroids are not benign drugs. Corticosteroids. Okay, so let's talk about congenital adrenal hyperplasia. Okay, it is an autosomal recessive trait. Okay, and so any of those enzymes that are necessary for synthesis of cortisol, okay, that there can be a deficiency. So you can see where that would be a spectrum of disease. Okay, the common characteristic is defect in synthesis of cortisol. And that's going to result in, when you have a decrease in cortisol, you're not going to get that negative feedback on the hypothalamus. So it's going to continue to produce ACTH to try to get those cortisol levels up. So what's going to happen is it's going to increase androgen production and or increase your aldosterone, depending on which enzymes are affected. Goes back to that diagram I showed you. So congenital adrenal hyperplasia, if it's a male child, often will have enlarged genitals, salt wasting, could have complete adrenal crisis. For a neonatal diagnosis, that's what you would expect. In a female child, okay, this is where that virilization occurs. Okay, and you probably learned about ambiguous genitalia and how, when the baby's delivered, can you not tell if it's a male or a female? This is a female. This is a female with congenital adrenal hyperplasia. Okay. And so what happens is that virilization, where you have hypertrophy of the clitoris, which is your female counterpart to the penis. And so it appears as a penis. The labial folds become fused. So it looks like scrotum. And that's how people can be confused. And sometimes it's not clear. Right? And so it has to do with a spectrum of that 21-hydroxylase deficiency. And so, yeah, without that normal cortisol production, you're going to have an over production of ACTH, which is going to divert those hormones. And yes, you can have salt wasting, you can have, and you can have virilization in a female, and you can have over enlarged genitals in a male. And so if it's the 11-beta hydroxylase deficiency, because these are two different enzymes in that process, depending on which one, that one's the rarer one, and this one is has a very broad spectrum of severity. Okay, and so that can lead to hypertension. This is, adrenal glands that were, on autopsy of a male who died 7 weeks old of congenital, hyperplasia. Okay, look at the size of those adrenal glands from overstimulation of ACTH. So hopefully the pictures help you put it in perspective and make sense. Okay, and we actually have to stop. All right, I've got 3 slides. Can we finish? Sure. Okay. 4 slides. All right. Adrenal cortical insufficiency on the other hand, okay? So that was hyperplasia. Another. If you have if you have primary adrenal insufficiency, if it's primary, it's Addison's disease, okay? The cortical hormones are deficient, so your hypothalamus is saying, produce, stimulating the pituitary. Pituitary is going to say, hi, spit out some more ACTH. Here you go. Come on, make aldosterone, okay? And, and it's usually, the most common is autoimmune destruction of the adrenal cortex. And so, as you can see, autoimmune diseases affect a lot of your hormone, your endocrine organs. And so this is not immune to it. Other causes are listed there. These are more rare. They're kind of all over the place, but you can see that it's probably, these can occur at any stage in life. And it can be due to things like tuberculosis, other infections that, get into the adrenal cortex, and hemochromatosis with the iron deposition in the adrenal gland, AIDS, etc. Okay. If it's secondary, we're talking about, usually it's because there's been some kind of injury to the pituitary. Okay, and so that would be, think about the things that can occur there. If it's tertiary, it would be the hypothalamus. The one that that we see most often is because of indiscriminate use of corticosteroids. Okay, and so this is us as providers, like the next slide on this. So, again, if you give somebody steroids over a long period of time, okay, you're giving them corticosteroids. It's going to shut down, it's going to provide that negative feedback to the hypothalamus and the pituitary, so it's not going to produce ACTH. So what's going to happen to all those receptors on the adrenal gland? They're going to down regulate, and the adrenal gland is going to actually atrophy over a long period of time. If you stop those steroids suddenly, it just can't rebound like that. And so even if the pituitary started producing ACTH again, there are no receptors. And so you're going to go into an adrenal crisis and potentially kill somebody. Okay, so, do not abruptly start steroids, stop steroids. You have to wean them off to allow that adrenal gland to start to pick up and make this all over again. Okay, your manifestations of the adrenal cortical insufficiency, you need at least 90% of destruction for the symptoms to occur. It's mostly related to your mineralocorticoids, your aldosterone, and glucocorticoids. So salt and water loss. You can have ACH hypersecretion. You can have decreased stress tolerance. Again, your norepinephrine and epinephrine. So that can lead to a decrease in your cardiac output and hypertension. With the loss of aldosterone, hyperkalemia, because Aldosterone gets rid of potassium, hypoglycemia because of the loss of cortisol, weight loss, and then GI symptoms. Parasympathetic's gonna take over. All right, your acute adrenal crisis, this is, life threatening, so, you know, this can be acute or subacute. There's your 5 S's of management. Just might help you in ClinMed. And then Cushing syndrome is the opposite end of the spectrum where you have an overproduction of cortisol, so hypercortisolism. So think about what cortisol does. If it's a pituitary adenoma, it is true Cushing's disease. Okay. If it's a true pituitary adenoma, which is really at the secondary level, it's Cushing's disease. Why? Because this is the guy who developed it, I identified it, his name was Cushing, and the first case that he identified was in the pituitary. Okay, you would think that pituitary disease or the Cushing's disease would be an adenoma in the adrenal gland, since it's the primary organ, but no. So anything else is Cushing's syndrome. If it's the disease, it's specifically a tumor in the pituitary. Everything else is syndrome because it's going to have the same net effect. Okay, buffalo hump, you know, striae, truncal obesity, peripheral wasting, the moon phase, all that. Okay, your adrenal tumors, if it is adrenal and it's Cushing syndrome, it's benign or malignant. If it's an ectopic production, you got to think, you know, ACTH production via small cell lung cancer, so paraneoplastic, and it can be iatrogenic due to our administration of long-term steroids. Okay, and so these are all the things that come with it. And I'm done. Thank you.
Great.